الرحمن الرحيم. برحب بحضراتكم في الموديول الأول في الدبلومة الجديدة. إن شاء الله تكون دراسة موفقة بإذن الله تعالى. وزي ما احنا متعودين فاحنا في آخر كل موديول بنعمل مراجعة على الحاجات اللي انتوا ذكرتوها، وبنعرض شوية حالات بتغطي معظم المنهج، وحضراتكم بتجاوبوا عليها عن طريق الشات وأنا بكومنت عليها بعد كده. وإذا كان في أي أسئلة بالنسبة لكم أثناء المذاكرة ممكن برضو بتسألوها على الشات وأنا بجاوب عليها يعني إن شاء الله. هنبتدي بقى الحالات and this is the first case of a patient with chest X-ray frontal view, and what do you think about this appearance? The answer, the boot shape, the heart, and they actually, you see that most of the cardiac shadow is shifted to the left side, considering that the patient is well centralized, and this means that there should be what's known as the depressed sternum or the pectus excavatum. You see that the sternum is markedly depressed in the lateral view and is compressing the heart, and the heart will be shifted towards the left side. But the pulmonary vasculature is good, the lungs are free, and the costophrenic angles are free also, and this is just pectus excavatum or depressed sternum. The second case is a male patient, 67 years old, and he is known to have spindle cell sarcoma of the thigh. And this is the chest X-ray. What do you think?
Metastasis.
And?
Right.
Yes, this is of course a metastatic deposit. What do you think about this? Yes, and someone answered that this is a pericardial cyst. No, this is metastasis, and this is also metastasis. If you have a positive history of a primary malignancy, then you should consider everything in the chest as metastatic deposits until proved otherwise. This is a big metastatic deposit in the right lung base. It is not a pericardial cyst and is not a pneumonic consolidation. You should consider everything in the chest as metastasis if you have a positive history of malignancy, unless the appearance does not fit with metastasis. Then the next case is the chest X-ray and the corresponding CT image of a cavitary lesion in the left lung base.
Bronchogenic carcinoma?
Yes, and this is bronchogenic carcinoma, the cavitating type of bronchogenic carcinoma, because the cavity has a thick wall and extremely irregular inner margin in spite of the fluid level inside, which represents hemorrhage, and the criteria of malignancy are fulfilled in this cavity. Next case is the chest X-ray of a patient with chest pain? Yes, the answer is right, and this is hiatus hernia, and the hernia is well seen in the lateral view. But if you see an air fluid level in this hiatus hernia, you should answer that this is an incarcerated hiatus hernia. It's no more sliding, it is trapped in the chest, and that's why it contains an air fluid level, and this means that it needs urgent intervention, in contradistinction to the sliding hiatus hernia. Next case is a male patient, 51 years old, with chest pain. Yes, the answer is TB, and this is right. Bilateral upper lobe strandy nodular opacities with cavitary lesions, and these cavities are well seen in CT scan. Then you should remember that cavities do not mean that this is an active disease. I have mentioned in the lectures that activity is diagnosed by the sputum or the presence of three embodied opacities in the lung, as seen in the CT scan. But cavities may be seen in patients with inactive TB and with patients with active TB. Next.
عفوا يا دكتور الكافيتي اللي كان موجود الحين
Now.
ده مش irregular
Yes,
in
yes, I know that, but you know that the cavitary lesions of TB, they are chronic cavities present for a long time, and there should be some fibrotic reaction around. But how can we discriminate from the cavitating bronchogenic carcinoma? Number one, by the location of the cavity. Number two, by the bilaterality of the cavity. Number three, by the strandy nodular opacities, and maybe calcium, sometimes seen in the surrounding lung parenchyma. Then this patient had calcified mediastinal lymph nodes, and this is the differential diagnosis: TB sarcoid, pneumoconiosis, or metastatic osteosarcoma.
sarcoid.
Yes, sarcoid is the right answer. And sarcoidosis frequently give calcified nodes in the mediastinum. And usually TB lymphadenopathy is not that pattern of calcification, and we usually see the TB in the subacute phase where you got necrotic center and marginal enhancement. And you cannot diagnose pneumoconiosis unless you see changes in the lung parenchyma, and you cannot diagnose metastatic osteosarcoma unless you know from the clinical data that the patient had this type of primary malignancy. The next case is a female patient, 70 years old, with shortness of breath, and she is a smoker.
Bronchogenic carcinoma.
Yes, right or left?
On the left side, on the right side.
Yes, on the right side. This is a bronchogenic carcinoma on the right side with the classic S sign of golden, and you see the bronchogenic mass or the tumor mass causing right upper lobe collapse, and the characteristic the S sign of golden with ipsilateral elevation of the diaphragm. Then, whenever you are asked in the exam, what are the radiological findings in a patient who is known to have a bronchogenic carcinoma? What are the possibilities to be seen in the plain film? Number one is a peripheral nodule with a speculated margin. Number two, enlarged dense hilar shadow. Number 3, pulmonary mass of whatever age and whatever contents. Number 4, central lesion with ipsilateral diaphragmatic elevation. Number 5, consolidation collapse due to bronchial obstruction. Number 7 is malignant pleural effusion. And finally, the S sign of Golden. This is a female patient, 50 years old, with recurrent chest infection.
Cystic bronchiectasis, Ustaz?
Yes, and this is cystic bronchiectatic changes. The only type of bronchiectasis that can be diagnosed from the plain film is the cystic type. And sometimes you can see air fluid levels inside the dilated bronchi, which means that this bronchiectatic changes are
Infected.
secondary infected, yes. And here you see the cystic dilatation of the bronchi, which are mainly seen in the middle lobe. And then the next case is a patient, 34 years old, with cough, fever, and chest pain.
This could be collapse. Bronchiectatic carcinoma.
There should be something to explain the cough and fever. The fever means that there is a type of infection here, and you have to decide whether this infection is present in the pleura or in the lung or both.
Both.
Yes, and we have some possibilities: massive pleural effusion, pneumonia with central breakdown, pneumonia and effusion, lung collapse, emphysema and pneumonia. Of course, yes, this is most likely the answer, but you need the help of CT, and this is CT, and you got an encysted pleural collection with an enhancing margin and some air loculi inside. This is empyema, and you got a heterogeneous consolidation of the right upper lobe, denoting pneumonic consolidation, and the answer is empyema and consolidation. This is the difference between the abscess and the empyema. Of course, you know that the abscess is around the structure and is not surrounded by collapse of the adjacent lung, but the empyema is elliptical in shape following the contour of the chest wall. It has the well-known split pleural sign and the underlying compression consolidation of the adjacent lung. Next case is a chest X-ray, frontal and lateral view.
Interstitial pneumonia.
Diffuse, you mean this is diffuse lung disease?
Diffuse lung disease bilaterally.
No.
More in the right.
Yes.
Enlarged left hilum, Ustaz?
And the left hilum is prominent because the patient is a little bit tilted. And if you look here in the lateral view, you see that the hilum is normal.
Normal chest X-ray.
And then right lower lobe pneumonia. Someone said this, and this is not lower lobe, of course. This is the middle lobe pneumonic consolidation, and you see this heterogeneous opacity, which is not similar to the left lung base. And in the lateral view, you see that the lesion is located in the middle lobe, and this is middle lobe pneumonia. Then if you ask about the definition of the cardiac shadow. Middle lobe consolidation will mask or cause silhouetting of the cardiac shadow, but actually this is not a whole middle lobe consolidation, and you got some part of the middle lobe that is consolidated, and the remaining part is not affected. Okay, next case. Next case is a patient with renal cell carcinoma, and he got this manifestation in the high resolution CT. And I provide the differential diagnosis of edema, infection, hemorrhage, neoplasm, or acute respiratory distress syndrome.
Neoplasm, Doctor.
Yes,
Neoplasm.
and this is
Lymphangitis, carcinomatosa.
it is not actually an interstitial opasties. These are alveolar opasties. But what's very important here is to remember the fact that if you know that the patient has primary malignancy, then you consider all the changes of the in the chest as metastasis until proved otherwise. And this patient has been treated as if he has pneumonia, but he got worse. And then biopsy showed that these are metastatic deposits. Then you consider every change in the lung is belonging to the primary malignancy until proved otherwise. Next case is a chest X-ray frontal view.
TB, Dr. Ustaz.
Yes,
TB.
and
TB.
TB and the fungal ball. Yes, and this is TB and fungal ball. You got cavities in the upper lobes, who is mass inside the cavity in the right upper lobe, and this is one of the well-known complications of TB. Next case is a chest X-ray of a patient in the ICU.
Deep sulcus sign means pneumothorax.
Right or left?
Left.
Left side. Yes, and this is just pneumothorax on the left side is not tension, because tension pneumothorax will depress the diaphragm and shift the heart to the opposite side. Then what do you think about this tube?
NGT tube.
Low position, Ustaz. Low position of tracheostomy tube.
Which tube?
Tracheostomy.
Tracheostomy tube. Is it in the right place or?
Right place.
Low in position.
It's good. Then what do you think about this line?
This is NG tube. That's not going into the stomach. It's going back to the coiling back into the.
It's introduced from the left subclavian vein. You see that this is the course of the tube. Sorry.
لا sorry.
Is not a central venous line. This is the Swan-Ganz catheter, you know, the Swan-Ganz catheter, which is used to measure the wedge pulmonary pressure. It is introduced into the superior vena cava, then the right atrium, then the right ventricle, then into one of the main branches of the pulmonary artery, about 2 centimeters distal to its bifurcation. And this is a little bit good position for this Swan-Ganz catheter. Next case is a patient with this chest manifestation. You got consolidation and some pulmonary nodules, and here the differential diagnosis: bronchogenic carcinoma with metastasis, lymphoma, alveolar cell carcinoma, metastatic deposits, bronchopneumonia.
Alveolar carcinoma, Ustaz?
Yes, and this is right. This is alveolar cell carcinoma with typical appearance on the chest X-ray and and the CT scan. You got areas of consolidation and another areas in the same lung or in the opposite lung showing pulmonary nodules. These nodules are the
Deposits.
precursor of these consolidations, and this is one of the supportive diagnostic criteria of alveolar cell carcinoma. You know that CT angiogram sign is also one
Sign.
of the signs, but this sign is not specific since it is seen in many of the lesions like pneumonias and infarctions, for example. One of the best appearances of alveolar cell carcinoma is a nodule or mass with air bronchogram inside. And this is one of the good possibilities for bronchoalveolar carcinoma. Also, the differential includes the lymphoma and round pneumonia. This patient is 85 years old and the chest X-ray was performed to confirm the position of the nasogastric tube.
It's in the normal position.
Yes, but the chest is not normal. Yes,
Diffuse lung
this
disease,
is right.
interstitial pattern,
This is aspiration pneumonia, and the answer is right. And you got some reticular opacities in the right side, which is a frequent site for aspiration. And because of the old age and the presence of nasogastric tube, you know that patients even with nasogastric tube may got aspiration pneumonia. Then this is CT scan, post-contrast axial coronal sagittal of this.
oncogenic cyst,
Yes, and this is the classic appearance of a bronchogenic cyst with all the simple cyst criteria and typical location below the carina. Next case is a 61 years old male with chronic myelogenous leukemia and recent onset of fatigue and cough. The differential diagnosis include TB, leukemic infiltrations, pneumonic consolidation, alveolar edema, alveolar cell carcinoma, alveolar proteinosis.
alveolar proteinosis, Ustaz?
The answer is right, but I cannot diagnose alveolar proteinosis from the plain film, but the CT is mandatory to reach the diagnosis whenever you see
Crazy
this
breathing,
crazy behaving
crazy
appearance,
breathing.
which is a classic appearance for alveolar proteinosis. And you know that alveolar proteinosis is not pathognomonic for alveolar proteinosis only, but it can be seen also in lipoid pneumonia, in alveolar cell carcinoma, and drug toxicity, sarcoid, some cases of non-specific interstitial pneumonias, especially in children, organized pneumonias, pulmonary hemorrhage, pneumocystis jirovecii, and some cases of acute respiratory distress syndrome. This is a CT scan axial and coronal, and these are the diagnostic possibilities. Massive effusion, emphysema with debris, mesothelioma with effusion, pleural metastasis with effusion, lymphoma with deposits.
Deposits with effusion,
Yes, and this is right. This patient had a breast cancer, and these are metastases from the breast cancer with pleural nodules and effusion. If you go back to the differential diagnosis, this is not emphysema because these are enhancing masses, and this is not mesothelioma because it is not continuous. and this is pleural deposits with effusion, okay for this, and also lymphoma with deposits is okay for this. But you should know to separate both the clinical picture of the patient, and if you know that this is a case of breast cancer, you diagnose metastasis. This patient, 34 years old, she is known to be a drug abuser, admitted with fever for 10 days when dyspnea, tachycardia. These are the differential diagnosis: TB, metastasis, septic emboli, sarcoid, alveolar cell, rheumatoid, Wagner.
Septic emboli.
Yes, the history is classic for septic emboli, and you know that septic emboli are diagnosed from the clinical picture of intravenous drug abuser or infective endocarditis, and the emboli are classically variable in size. The larger one will cavitate, and the smaller one will appear as solid nodules. The clinical picture is very, very important to reach the diagnosis. These are the causes of septic emboli: endocarditis, drug addiction, alcoholism,
Endocarditis.
skin infection, immune compromise, and infected catheters. And this is a classic appearance of cavitating and non-cavitating septic emboli. This is also a septic emboli. You need, as I have mentioned, you need very, very important, you need the history to reach the diagnosis. The emboli will cause nodules in the lung, and the nodules, if they are a little bit large, they will appear as cavities. Next case is a male, 55 years old, with right shoulder pain and neck pain.
Bronchogenic carcinoma.
Oncogenic carcinoma.
Yes, and this is Bankos tumor, which is a type of bronchogenic carcinoma occurring at the lung apex or the superior sulcus, and it's classically associated with destructive changes in the adjacent ribs. This is very important. Next case is a patient with progressive dyspnea but no fever. I think there is a differential diagnosis as TB, fibrosis after TB, pneumoconiosis, sarcoidosis, histiocytosis.
Fibrosis after TB.
And it is progressive massive fibrosis. It's of course not that apparent in the plain film, but you see in the CT scan two big masses in the upper part of the chest with dense calcification, and these are diagnostic of progressive massive fibrosis. It's easy from the CT scan, and it is easy also from the plain film if they have the classic presentation. This is chest X-ray, and the history is cough and fever, I think.
Lung collapse.
Left or right?
Right.
Total lung collapse.
atelectasis. لا مش
S shape to the S golden shape.
Bronchogenic, you mean?
Yeah.
No.
Combination
Look to
that.
the CT scan of the same case. What do you think?
right lung collapse.
It's not total collapse, but
TB.
TB should affect the apex of the lung, and this pattern affects most of the right lung. Look to the plain film. If you see consolidation with air bronchogram, what do you think?
Pneumonia.
Yes, and this is the first diagnostic possibility of a consolidation with air bronchogram if you do not have other history to support other possibilities. Next case is a female patient, asymptomatic, and you see this big mass in the chest. The diagnostic possibilities hydatid, bronchogenic metastasis, schwannoma, esophageal duplication cyst.
Hydatid.
Duplication cyst, Ustaz?
Duplication cyst. There is an important point here to remember. Yes, the answer is right. Schwannoma is right. And you know that this is a posterior mediastinal lesion. From the plain film, you see that well definition of the cardiac border, and from the CT is located posteriorly. And you should remember that schwannomas appear in the CT scan as if they are cystic. But whenever you introduce a needle to have some fluid from this lesion, you see that it's solid and no fluid is coming from the needle. Then you introduce the core biopsy needle and you got a core biopsy. This is classic appearance of a schwannoma. Actually, you got some difficulties to discriminate between posterior mediastinal lesions and pulmonary masses. Unless this lesion is going inside the neural foramen, then you know that it is of neurogenic origin. But as I have mentioned in the lectures, that these masses will be biopsied, of course, in order to settle down the diagnosis. But keep in mind that this border is not the border of a bronchogenic carcinoma or a metastatic deposit. Yes, next case, and this is a patient, female, 61 years old, with this lesion in the right lung base. The possibilities: bronchogenic, lymphoma, alveolar cell, metastasis, bronchopneumonia.
Bronchogenic carcinoma.
Bronchogenic carcinoma does not contain air loci, or let us say air bronchogram. Yes?
Pneumonia.
No, this is a solid mass. It's not an infection.
Bronchoalveolar carcinoma.
Yeah, the two possibilities are the lymphoma and the bronchoalveolar carcinoma. You remember that if you got a mass with some air bronchogram inside, you think of one of three: round pneumonia, alveolar cell carcinoma, and the lymphoma. This lesion was biopsied and proved to be pulmonary lymphoma. Next case.
Tension pneumothorax.
Yes, and this is tension pneumothorax because of the marked depression of the diaphragm and the shift of the heart to the opposite side. Next case.
Brachial malacia.
Yes, tracheomalacia, and you see the difference between the tracheal air column in during inspiration and expiration, and this is pathognomonic of weakness of the tracheal wall, which is diagnostic of tracheomalacia. This patient is male, 57 years old, with blunt abdominal trauma several years ago in a motor vehicle
Hernia.
accident. Sorry?
Hernia.
Hernia.
Rupture.
Yeah.
Rupture. Yeah.
Rupture of the diaphragm. This is right. There, you know that the diaphragmatic rupture, if not diagnosed immediately, it will last for years after that. Then this is diaphragmatic rupture because of the history of trauma, and these air fluid levels are in the bowel loops that have herniated inside the left hemithorax. Then the next case is male, 56 years old, who is present in the ICU. And this is the initial film, and this is the film obtained 12 hours later.
Mucus plugging.
Yes, very good. Yes, this is mucus plugging, and in such cases, you should look first for the position of the endotracheal tube, because if it is displaced a little bit, it will pass into the right main bronchus and obstruct the left main bronchus, and this will happen. But if you realize that the endotracheal tube is located at its usual position, then you think of mucus plug, which will cause rapid consolidation and also rapid aeration and resolution after some time. Next case is a chest X-ray and CT scan of a patient with dyspnea, cough, and no fever.
Scleroderma.
Sorry?
Scleroderma.
Yes, and this is right. Very good answer. This is scleroderma because of the esophagus. If you look carefully here and you see the markedly dilated atonic esophagus filled with air, and the changes in the lungs which simulate pulmonary fibrosis. But in the presence of this pathognomonic finding, you can diagnose easily the possibility of scleroderma. Next case is a male child, 6 years old, and he got a mass on the left side. These are the diagnostic possibilities: bronchogenic carcinoma, lymphoma, teratodermoid, metastasis, hydatid.
Teratodermoid cyst.
Okay, this is the CT scan of the patient, and if you look carefully here, you can see calcium. And this calcium is supportive of the diagnosis of teratodermoid cyst, especially in this age group. But this is not the calcium of hydatid cyst, and you remember that hydatid cyst in the chest, in the lung, does not calcify. Then this calcium should be present in one of the lesions that can calcify, and teratodermoid cyst is the most likely. And CT showed the presence of fat as well as calcium and the fluid, diagnostic of teratodermoid cyst. Next case is a male patient, 48 years old, with back pain, CT MRI.
Neurogenic.
Neurogenic tumor.
Hydatid cyst?
Yes, this is a classic appearance of hydatid cyst as seen in this image in particular. You got a big cyst with a small daughter cyst arranged peripherally, and is also seen in this axial image, but not well appreciated in this CT image. This is a mediastinal hydatid cyst, which is considered one of the rare conditions. Okay, the chest X-ray, frontal view and lateral view.
There was obesity in the left lung field.
Yes, and this is upper lobe or lower lobe.
This is upper lobe.
Yes, of course. Upper lobe because of two main things. Number one, you cannot see the cardiac border. Number two, you see that the lower thoracic vertebrae are black. And if this is the lower lobe, it will be superimposed on the spine, and the spine will be bright or have some increased density. And because of the silhouette sign with the heart, and the appearance of the lower dorsal vertebrae, and you consider this is upper lobe, and this is upper lobe consolidation and collapse because the fissure bordering the upper and lower lobe has been displaced anteriorly, and this is the sorry. Okay. مش عارف ايه اللي حصل لكن okay. Then this is the appearance of the upper lobe consolidation collapse, which is presented here in yellow, and the collapsed lobe will go towards the mediastinum, and in the lateral view the fissure will be displaced anteriorly. Then next case.
Nodular vertebral.
Yes, and if you look here, and there are some lymph nodes in the mediastinum, and some consolidation. In the lung window, you got the classic perilymphatic distribution. And this perilymphatic distribution is impressive of one of two, either the sarcoid or the lymphangitis carcinomatosis. Then if you know that the patient had renal cell carcinoma, then you know that this is metastatic deposits and the lymphangitis carcinomatosis. Then next case is the patient with breast cancer, and this is the chest X-ray.
Sclerotic metastasis, Ustaz?
فين?
Sclerotic metastasis,
Yes,
increased density of the vertebra.
Yes, and this is very important, of course, because if you know that the patient had breast cancer, you start looking at the lung and the mediastinum and the costophrenic angles. But many times you forgot to look at the vertebral bodies, and this is the normal appearance of the vertebral bodies here. The vertebrae are too much sclerotic, and these are metastatic deposits in the spine. Next case is a male patient, 75 years old, with dyspnea and impaired pulmonary function. He is a heavy smoker. This is the chest X-ray.
Diffuse lung disease, interstitial bacterium.
Yes.
Histocytosis.
No, interstitial histiocytosis is not in the differential diagnosis of interstitial lung disease, but the interstitial is the right answer. And if you go to the CT scan, and you can see this pattern, which is diagnostic of
Honeycombing,
traction, honeycombing, which is the classic pattern of usual interstitial pneumonia or idiopathic pulmonary fibrosis. Very good. شكرا جزيلا، ونراكم على خير إن شاء الله، موفقين بإذن الله تعالى، والسلام عليكم.